Ventricular preexcitation. Ventricular preexcitation is defined as ventricular depolarization via a bypass tract, earlier than expected if the impulse passes in the atrioventricular node and his Purkinje system. It is usually partial, that is, some parts of the ventricles are preexcited via the bypass tract, while the rest of the ventricles are depolarized normally through the AV node, resulting in a fusion QRS complex. Preexcitation may, however, be complete where the whole ventricles are preexcited via the bypass tract. Atrioventricular connections. Normally, only the atrioventricular node allows electrical contact between the atria and the ventricles, while otherwise they are electrically isolated. In preexcitation, one or more additional conductive pathways are present, called the accessory pathways or the bypass tracts. Physiological differences between the atrioventricular node and the bypass tracts. 1. The normal electrical depolarization wave is delayed at the atrioventricular AV node, but not in the bypass tracts. 2. Bypass tract conduction velocity is usually faster, and less unhealthy. 3. The AV node limits the number of supraventricular impulses passing to the ventricles, while healthy bypass tracts do not. 4. Decremental conduction is a famous characteristic of the AV node, but rarely occurs in bypass tracts. 5. Dual physiology occurs in some persons in the AV node but not in bypass tracts. 6. Ventriculoatrial conduction, retrograde atrial activation, is concentric with AV node, but usually eccentric with bypass tracts, unless the bypass tract is very close to the AV node. Retrograde atrial activation. Retrograde atrial activation was discussed earlier in details. With normal retrograde conduction via the AV node, following ventricular stimulation, the earliest atrial activation, A wave, in intracardiac recordings appears in the His bundle channels, followed by radial concentric spread of the impulse in the atrial septum, then in the atrial free walls, almost simultaneously in both atria. Retrograde A waves may appear in the coronary sinus channels, which record the low left atrium nearer to the ventricles, a little earlier than the high right atrial channel. Bypass tracts. Bypass tracts are composed of atrial-like muscle fibers. They can occur in any combinations, on either side of the heart, involving the atria, ventricles, AV node, bundle of His, or fascicles. Bypass tracts may produce specific changes during sinus rhythm on the 12-lead ECG, that will provide clues to their location. Types of bypass tracts. 1. Atrioventricular, AV, bypass tracts, known as Kent fibers, directly connect the left atrium to left ventricle, or right atrium to right ventricle, and insert distally in the ventricular muscle. 2. Atriohischian bypass tracts, from either atrium to the His bundle. 3. Atrionodal bypass tracts, known as James fibers, connect either atrium to the AV node. 4. Intranodal bypass tracts are claimed by some, while others consider this type just an accelerated AV node conduction, rather than a true anatomical bypass tract. 5. Atypical or slowly conducting bypass tracts, known as Maheim fibers, connect distally to a fascicle, atriofascicular or nodofascicular, or to ventricular muscle near to the conduction system, nodoventricular or His ventricular. Any combinations of the above may also coexist. Schematic showing bypass tract locations: atrioventricular, atriohischian, atrionodal, intranodal, atriofascicular, nodofascicular, nodoventricular, and His ventricular. Clinical significance of preexcitation syndromes. The term syndrome is used when an anatomical variant of bypass tracts is responsible for a tachyarrhythmia. Although uncommon, bypass tracts can be life-threatening, since rapid potentially fatal arrhythmias are far more common in these patients than in the general population. Correct diagnosis is essential, because the wrong treatment can worsen the problem. Some drugs used for treatment of supraventricular tachycardias can accelerate the ventricular rate, and may even be fatal. Details of ECG changes. ECG changes may occur during sinus rhythm in patients with bypass tracts, if they conduct anterograde, including 1. Short PR interval. The QRS occurs earlier due to faster anterograde conduction in the bypass tract. 2. Delta wave. That is an abnormal slurring at the start of QRS, which represents early depolarization of variable parts of the ventricles. Delta waves are present when the bypass tract inserts in muscle fibers, but they are usually absent when the bypass tract inserts into or close to the his Purkinje system. 3. QRS complex widening greater than 100 millisecond, because a part of ventricular tissue depolarizes near the bypass tract before the rest of the ventricles, and does not spread via the normal his Purkinje system. ECG changes that may occur during sinus rhythm in patients with ventricular preexcitation. 1. Short PR interval. 2. Delta wave. 3. Wide QRS greater than 100 millisecond. Types of preexcitation syndromes. 1. Wolff-Parkinson-White, WPW, syndrome, is associated with AV bypass tracts. During sinus rhythm, ECG shows short PR, wide QRS, and delta waves. 2. Loewen-Ganong-Levine, LGL, syndrome, is associated with atriohystogen, atrionodal, and intranodal bypass tracts. During sinus rhythm, ECG shows short PR only, then conduction is normal in the his Purkinje system. 3. Mannheim variant of preexcitation, is associated with the atypical bypass tracts, atriofascicular, nodofascicular, nodoventricular and his ventricular. These fibers conduct relatively slower than other bypass tracts, and the normal conduction system has enough time to depolarize most of the ventricles. ECG during sinus rhythm shows little widening of the QRS, and does not usually show delta waves or short PR. QRS complexes in patients with manifest preexcitation syndromes. In preexcitation, the QRS is a fusion beat resulting from ventricular activation by two anterograde wave fronts, one in the his Purkinje system and the other in the bypass tract. The degree of preexcitation, amount of muscle activated through the bypass tract, is variable, and depends on many factors, particularly the differences in conduction times through the his Purkinje system and the bypass tract. With increasing degrees of preexcitation, anterograde AV conduction proceeds more and more in the bypass tract than in the AV node, and more ventricular muscle mass is depolarized by the bypass tract wave front. ECG manifestations are also more prominent, that is the PR is shorter, delta wave is bigger, and QRS is wider. With total block at the AV node or his Purkinje system, the impulse is conducted exclusively in the bypass tract, the whole QRS complex is generated by the pre-excited impulse, and looks different from fusion beats, but with no change in delta wave direction. Variable degrees of pre-excitation are shown in this figure, little on the left, more on the middle, and almost complete on the right side. Concealed bypass tracts. Concealed bypass tracts cannot be detected by inspection of the surface ECG because they do not conduct anterograde, and therefore do not result in ventricular preexcitation. Concealed bypass tracts, however, can conduct retrograde, thereby creating a reentrant circuit with impulses traveling from the atria in the AV node to the ventricles, then back to the atria via the bypass tract, that is, they can participate in an orthodromic AVRT. Intermittent preexcitation. True intermittent preexcitation is defined as the presence and absence of preexcitation on the same tracing, with abrupt loss of ECG manifestations of preexcitation, loss of the delta wave, normalization of the PR interval, and normalization of the QRS, in the absence of any significant change in heart rate. Abrupt change means that it occurs from one beat to the immediately following beat with no gradual change over several beats. This figure shows intermittent preexcitation. Some beats are pre-excited, indicated as pre, while others are normally conducted, indicated as N. The change is abrupt, and occurs in the absence of significant changes in heart rate. Pre-excitation manifests in intracardiac tracings as shortening of the HV interval, intraventricular conduction time. First two beats are pre-excited, while the next two beats are conducted normally, with normal HV. Causes of intermittent preexcitation. Intermittent preexcitation indicates intermittent block of anterograde AV conduction in the bypass tract, which may be caused by 1. Rate-dependent block, phase 3, bradycardia-dependent, or phase 4, tachycardia-dependent, block. 2. Refractory bypass tract due to concealed conduction, either anterograde by premature atrial beats or atrial tachyarrhythmia, or retrograde by premature ventricular beats. 3. Unhealthy bypass tracts, with long anterograde refractory periods. Significance of intermittent preexcitation. Intermittent preexcitation is generally a reliable sign that the bypass tract has a relatively long anterograde refractory period, and is not capable of excessively rapid impulse conduction, such as during atrial fibrillation, that is a low-risk bypass tract. Special forms of intermittent preexcitation. Preexcitation alternans, in which a preexcited QRS complex regularly alternates with a normal QRS complex. Concertina preexcitation, in which the PR and QRS durations show a cyclic pattern, that is, preexcitation becomes progressively more prominent over many cycles, followed by a gradual diminution in the degree of preexcitation over several cycles, despite a fairly constant heart rate. Inapparent preexcitation. In this condition, preexcitation is absent on the surface ECG, despite the presence of an anterogradely conducting bypass tract, because anterograde conduction over the AV node His-Pourquenier system is relatively faster than that over the bypass tract. Causes of inapparent preexcitation. Inapparent preexcitation is a broad term used to indicate the absence of anterograde conduction in a bypass tract, due to any of the following. 1. Enhanced AV node conduction over bypass tract conduction. 2. Depressed bypass tract conduction. An extreme form is the concealed bypass tracts, which have permanent anterograde block and represent an advanced form of inapparent preexcitation. 3. Prolonged intra-atrial conduction from the site of atrial stimulation to the atrial insertion site of the bypass tract, most often seen with left free wall bypass tracts, favoring anterograde conduction over the AV node His-Pourquenier system. Differentiation. Maneuvers that slow AV node conduction, such as carotid sinus massage or AV node blockers, give chance for the bypass tracts to conduct more, thus they would unmask inapparent preexcitation secondary to enhanced AV node conduction. These maneuvers would not affect intermittent or concealed preexcitation, in which the bypass tract is unable to conduct anterograde, either intermittently or permanently. Thank you.